Hello, colleagues. My name is Erica Marshall, and I am excited to present about my research proposal topic, trauma-informed substance use prevention outcomes in high ACE minority adolescents. If you don't know what ACE stands for, it stands for adverse childhood experiences. Some examples include abuse, neglect, abandonment, um, trauma in those who are 0 to 17 years of age. It can have a significant impact on not just your physical health, but also your mental and emotional health, especially in adolescents who are in that critical period of development where they're just searching for ways to cope. In particular, minority adolescents are at higher risk for trauma exposure due to some systemic inequities such as poverty, community violence, limited access to mental health support services, just a few examples. Minority youth with four or more adverse childhood experiences have a higher likelihood to experience behavioral issues, depression, and substance use disorders. So, despite the interventions that might exist, a significant number of them are short term and they're not culturally adapted to support minority youth with higher ACEs scoring. And very few of them measure long term outcomes beyond pre and post evaluation. So this study aims to be able to evaluate the effects of a 12-month trauma-informed substance use prevention program to determine SUD risk, to lower SUD risk, and trauma-related behavior scoring among minority adolescents. Black and Latinx minority adolescents who have experienced four or more ACEs. This study also aims to evaluate the perception of trauma-related behaviors pre and post intervention. The research questions to consider are: how does participation in the 12-month trauma-informed substance use prevention program reduce both SUD risk and trauma-related behavior scores among minority adolescents ages 12 to 17 who have experienced four or more adverse childhood experiences? Also, what perceptions of changed behavior do adolescent youth with four or more ACEs experience by participating in a 12-month trauma-informed prevention program? The hypothesis is that participation in this program will yield significantly lower substance use disorder risk scores, as well as trauma-related behavior scoring at the 6-month and 12-month follow-up in comparison to those reported at the baseline. In total, the timeline for this project is 24 months, but the intervention itself is 12 months, and it is a mixed method quasi-experimental longitudinal design to determine how a 12-month trauma-informed program affects adolescents with higher ACEs scoring. The participants are going to be Black and Latinx youth, so ages 12 to 17, a minimum of 120, half being in a control group, half being in an intervention group. And they'll be recruited through urban settings such as schools and through community partners such as youth serving organizations and programs, local churches, behavioral health clinics, and other relevant community-based organizations. And they will be recruited through a referral process, which will engage specifically case managers, community health workers, youth advocates, those who fit the bill who can meaningfully support youth. Quantitative data collection will look like risk scoring through a craft tool, as well as trauma-related behavior scoring using the child and adolescent trauma screening. Quantitative data will be collected at the baseline mark, at the 6-month mark, and at the 12-month mark. At the end of the 12-month intervention, there will be small groups to collect some of that qualitative data, where participants will be asked to answer some questions around their pre and post intervention experience, and there'll be a thematic analysis used to identify some common themes. Some ethical considerations to keep in mind is that because this is a vulnerable population, specifically minors, those who are trauma exposed, informed assent for minor youth will be required, but there'll be an option to waive parental consent if parents are not the safe space, parents or guardians are not the safe space to be able to provide consent for participation. Also, a mental health professional will be accessible throughout the implementation period. The program will go through the institutional review board to note all feedback given, make necessary changes for approval. To minimize risk, all personal identifiable information will be kept confidential, stored, and password protected. Also, the project implementers will receive training on trauma-informed care. Um, in addition to the IRB, the Community Advisory Board will work closely with the intervention team to be able to provide necessary feedback around how the priority population is recruited, cultural sensitivity, emotional safety, making sure that The intervention that's implemented is culturally relevant, and that the evaluation process is suitable for the population that will serve. Following the 12-month implementation period, some of the anticipated results include lower SUD risk scoring compared to the baseline in the 6-month and 12-month follow-ups. Also, participants will be able to offer feedback in the focus group that includes feelings of empowerment, increased sense of self-awareness, a stronger sense of community, and a stronger system of social support, and overall just a more positive outlook on life and positive behavioral changes. In addition, we hope that the participants as well as the community advisory board will report that the study was both culturally relevant and compassionate, hopefully yielding high levels of acceptance and community buy-in. From a biblical standpoint, caring for those who have been deeply affected by trauma and hardship really reflects the heart of Christ. So we know that in Psalm 34:1, we're reminded that God is close to those who are brokenhearted, offering a space of comfort and healing. Furthermore, as public health leaders, we're challenged in Proverbs 31:8 and 9 to advocate and defend for those who are voiceless and defenseless. And this study is a way to be able to walk that out in a practical sense, and follow that command that Christ has given us to love our neighbors as ourselves, to watch out for those who are the least of these. So, in conclusion, trauma exposed minority youth need a safe space to be able to process and to be able to heal if we want to see more positive outcomes concerning them. They're at higher risk for developing substance use disorders, but the gap still exists in research to show those long-term intervention efforts. This study will add to research through the collection of 12 months of qualitative and quantitative data for a population that is disproportionately impacted as well as understudied. So, on a policy level, the success of the program can prove the need for an increase in resource allocation for community-informed early intervention efforts. And overall, ACEs awareness can support youth who may be seen as problem kids and help us to view them through a lens that is more compassionate and meaningful as we find sustainable approaches to lower SUD risk. Thank you so much for listening to my presentation, and I look forward to your feedback.